Hello and welcome to the Dementia Doctor. Today I have Dr. Tran here and he will share his research in relation to obesity and Alzheimer's disease. Welcome, Dr. Tran.
Thank you. Pleasure meeting you here.
We would like to know more about you. Please let us know who you are and what you do.
My name is Lloyd Tran. I'm the CEO of Biomed Industries Inc. We are located in San Jose, California. My job is to oversee the operation of the research program of the company, but I'm also a scientist by training. I'm the inventor with several patents. I'm really deeply interested in the scientific aspect of research. Our interests have two angles. One is Alzheimer's disease, and second one is the association between Alzheimer's disease or neurodegenerative diseases and metabolic, such as obesity.
This is very interesting for our listeners. Could you tell us more about your research with Alzheimer's disease and metabolic syndrome or obesity?
Thank you. We are focusing on Alzheimer's disease. The history dates back to about more than 15 years ago. My dad suffering from dementia, AD, and passed away with Alzheimer's disease. So I was very interested to learn more about the disease. It is one of the dreadful diseases, you can tell. Not only affect many million patients, but also affect the caregivers and the family with the loved ones suffering from diseases. So our interest is look at the research of the past 20, 30 years. As you know, over the past 20 plus years, most research been focusing on anti-amyloid. People thought that the disease is caused by the build-up of a certain protein called amyloid beta. And as a result, most of the research from big corporations focus on that, even today. The results are not very promising, even though a lot of results, money, and time involved. Many years ago, my team and I believed that the disease is more than amyloid. We believe that amyloid is one of the important elements, but it's not the center of the universe for AD. We do research on what's happening in the brain, particularly in the area called hippocampus. Hippocampus is a center of memory and cognitive functions. So we deep dive look at it and we found that before amyloid beta can be observed, something happening in the hippocampus. In fact, many patients suffering from disorder in the hippocampus first before you can measure the amyloid. Animal studies showing that by observing the animal, we found that the neurons generated all the time in the hippocampus. In fact, recently studied by University of Illinois, they found the biopsy of two groups of people. Some patients have AD and some patients have sound mind. And these people are 75 years to 87 years of age. Two groups. And they agree that their brain will be removed right after they pass away. Research shows that for many patients, majority of the cohort patients who have AD, they appear lack of ability to make new neurons in their hippocampus. But for the sound mind patients, the evidence showed that there were many neurons generated in hippocampus just before they die. So it confirmed the theory that hippocampus is the place where we should look closely. In addition to that, research showed that the anti-amyloid may not be the determining factor because many patients who have dementia AD, even though they have a lot of amyloid, but there's some healthy sound mind patients have a lot of amyloid, but they still have a healthy brain, right? So I think we have to look at closely. What we did at Biomed is that we developed a drug called AD for NA-A31. This drug has interesting mechanism of action. What it does is that it stimulated the making of neurons in the hippocampus. It actually regenerated new neurons to replace old, tired, or even wounded, or even dying neurons. And this is our method of approach, and we have finished the phase 1, phase 2, so promising. Our results have been shown and published in medical journal, and we present at international conference such as Alzheimer's Disease International Conference, AIC, and also CTAD, like the one we are today, participant today. So thank you for the opportunity to tell you about our story.
Yes, absolutely. This is such an inspiring story, and the journey is very similar to mine, where I had family members suffer from Alzheimer's disease, and then I decided to dedicate the life to Alzheimer's. And you told us about so many interesting things for our listeners. So, of course, when we think about Alzheimer's disease, we think about the two bad proteins that are known to accumulate, the amyloid protein and the tau protein. But what we are trying to say is that it's also, there could be inflammation, there could be other things, including the fact that our memory center, hippocampus, makes neurons, new neurons, and its size is very important for us to have good memory. And in that study that you were describing with the biopsy, you said that the brains of people who were healthy had the memory center, hippocampus, still producing new neurons. So I'm interested in knowing, is this what you are looking at, the size of the hippocampus and the ability to produce new neurons? And we talk about the metabolic syndrome, like having obesity, having high blood pressure, having cholesterol, all of this. Does that lead to inflammation in the brain, or how does it cause memory problems in people?
Very good question. In fact, it is a very complex question that we're still searching, and I'm sure many scientists around the world are looking for multiple angles of dementia and memory loss and cognitive functions. They are multi-factor. In fact, Alzheimer's disease is not just a single disease, it is a multi-faceted disease. So what we learned so far is that we find there is an interesting association between neurodegenerative diseases such as Alzheimer's disease and metabolic disorder such as obesity. In fact, you may recall, Doctor, a long while ago, people thought that Alzheimer's disease is the third type of diabetes.
Yes.
Yeah, because the brain is not something compartmental. Our brain is a marvelous organ. Mother Nature gave us a wonderful, very intelligent, small but extremely intelligent. And in that center of knowledge, memory, cognitive functions, it controls the entire function of our body, including our thirst, our hunger for food, and also our understanding what's going on. So in the common sense, there is a strong linkage between memory, cognitive functions, and metabolics. Now the evidence is begin to come forth. We have a study recently published, actually in the CTAD, we have a paper called the Association of Alzheimer's Disease and Obesity. Rather than speak in a very general term, we show the evidence of our own two drugs, NA831 for AD and NA931 for obesity. These two drugs are interrelated. They're not far different, but they're not the same. We synthesize the drugs such that each drug have a different focus, different target. Our Alzheimer's drug target AD and our obesity drug target metabolics. And we found that the results are very interesting, such that there is a strong linkage between the mechanism action of both drugs for two appear to be different, obesity and dementia. So what benefit that? The benefit that it is give us a strong scientific evidence that help clinicians, your doctors, your colleagues in clinician take care of the patient. For many neurologists take care AD patient, they need to understand the metabolic condition of the patient by not only observing the obesity characteristic, but there's something else, including insulin resistant, potential diabetics, pre-diabetics. These affect the treatment for Alzheimer's disease. Vice versa, for obesity specialists, it's good for them to understand if the patient have some kind of mild cognitive impairment, MCI, or early onset of Alzheimer's disease. It helps them to have a complete, holistic profile of the patient, help them to determine the dose, the medication for treatment.
Yes, I agree totally with this. Having a holistic and a comprehensive approach to our seniors and family members that we see in the clinic. So a lot of times we see individuals who have these mild memory issues. They also are suffering from cholesterol, diabetes, or overweight or obesity situation. And hopefully your drugs that are in the developmental pipeline will help address both the issues at the same time, helping with the weight loss as well as with the memory. And as I understand, your medications right now, the drugs are in phase 2 of the clinical trials?
Yes, we have finished the phase 2 for both AD and obesity, and now we are launching the phase 3 for both drugs.
Okay. How are these medications different from the GLP-1 agonists, the semaglutide and those medications? Is your drug similar to them, or is it different with those medications?
Thank you for the question. We have 2 drugs, A31 for the treatment of Alzheimer's disease. It is the oral medicine taken daily in the term of the capsule. And the mechanism action of this drug is to catalyze and create the new neurons in the hippocampus. So it works in conjunction with current standard of care today. Today we have 2 drugs in the market. One is lecanemab by Biogen Eisai, and the second drug is donanemab by Eli Lilly. Both are intravenous infusion, either weekly or bi-weekly or monthly, depends on the condition of the patient. So we believe that our drug oral could work in conjunction in the combination therapy and oral plus intravenous infusion. The second drug we refer to is the drug for obesity. This drug, the mechanism is actually a little bit more complex. As you may be aware, in today, the drugs like semaglutide by Novo Nordisk and tirzepatide by Eli Lilly. Both are GLP-1 single for semaglutide or double GP1 and GIP for Eli Lilly tirzepatide. Our drug NA31 is a quadruple 4. It has 4 receptor agonists.
Okay.
Why 4? Let me tell you the reason why. When you introduce a drug like GLP to the body by injection, that drug work, it actually imitates the natural GIP. It actually control the weight loss, control the weight by reduce the hunger, losing the thirst, the hunger, make the patient losing weight. On one hand, it's good because you can lose weight. On the other hand, it causes something like Ozempic syndrome, where people, don't feel well to lose weight suddenly, right? The second drug, like tirzepatide, it have GLP and GLP-1 and GIP. Actually, it mitigates the adverse events much better than GLP-1.
Okay.
The drug we introduced is quadruple. It have 4 receptor agonists, including GLP-1, GIP, glucagon. And the fourth one is IGF-1.
Okay.
IGF-1, Doctor, IGF-1 is a very important growth hormone. IGF-1 actually control the way we function in the brain, but also the healthy growth of the baby to become an adult. The IGF-1 have a very strong interlinkage with GP1. By having GLP-1, it actually work in harmony. It actually achieve the so-called the balance or homeostasis. Because of that, we have put a hypothesis that by introducing IGF-1, we hope to prevent the situation of adverse event caused by muscle loss. One of the major problem, adverse event of GP1 is many patients suffering from losing the muscle strength, because the muscle represent about 40% weight of our human body, right? So when you lose the fat, you also lose the muscle. By introducing IGF-1, which known to be a muscle builder, we hope to stabilize the muscle loss, or at least to prevent muscle loss. our phase 2 data show that during the investigation, we have no observation of muscle loss at that time, but we're still waiting for phase 3 studies. I cannot say definitely, but
Yes.
so far the results are very promising that by using a quadruple receptor agonist, we hope to achieve a better balance to help the patient managing weight.
Yes, absolutely. So, as I understand, it's different from the GLP-1 agonist, which act probably on only one receptor. Your drug, you're saying it acts on 4 different receptors, and one
Right.
of them is the GLP-1,
GIP
GIP,
and glucagon,
glucagon,
and the fourth one is IGF-1.
IGF-1.
It's a long name,
So,
but
yeah, a lot of alphabet soup and a
Alphabet,
lot
yeah,
of
right.
acronyms. So, because it's acting on different receptors, it preserves the muscle strength, and that's how it's primarily different from the other
That's right.
medications we talked about. And as we know, when we lose weight, there's a big chance that we lose muscle weight.
Yes.
And as we lose muscle weight, we can have falls and frailty, which is commonly seen in elderly. So, this is a good point of difference where your medication just makes us lose the fat and not the muscle. So
Yes.
that's really interesting.
Yeah. In addition, I must say that the drug is oral formulation.
Yes.
Oral, so we hope the patient can be easy rather than make injection.
Yes.
Weekly or monthly, it is oral, daily oral. Yeah.
Yeah, and then the other interesting part is that it could be taken with the infusion therapies safely, which
Yes.
are the other common infusions for anti-amyloid medications that we know. Is there any other message you have for our families and caregivers before we end?
I
the
think
talk?
I'm fully understand the challenge facing of the patient, but also caregivers. My family go through that experience, so myself understand. So I think the burden is that we believe that there's a hope on the horizon. Not only we, but many our colleagues at the conference like CTAD, we see many our colleagues work on multiple approach, and we hope someday there's some solution for treatment and particularly prevention of Alzheimer's disease. I firmly believe that dementia and Alzheimer's disease can be prevented or can be delayed as further possible. So not only because when you start treat the patient who have in the middle of severe cases of AD, it's very difficult to treat the patient. But if you're able to identify through many diagnostic methods, like blood-based diagnostic or other method, so we allow the patient to be taken care of well in advance. And I think it prolongs the time frame, and also it gives the patient, the caregivers, some hope in the future.
Absolutely. Earlier interventions in Alzheimer's disease and other dementias are known to prolong the cognizant time for families. So it means one more Christmas, one more Thanksgiving with the
Exactly.
family. So thank you so much for coming to our channel and describing your research. This is really hopeful for our listeners. Thank you.
Thank you very much for the opportunity.